Call me or text me the second that you get this message, okay?
Tell you later.
Okay. I can't reach Jake.
I'm sure it's okay.
Active shooter at Pitfest.
We heard.
Department now. Post triage. Emergency department now.
What's that mean? Has that happened before?
We're locking down the hospital and setting up a command center and administration. We'll coordinate logistics, supplies, communication.
How many casualties?
Unclear, but initial reports are not good.
So we're in the last hour of this shift here, and it almost goes by so fast that you can't hear it. She says there's been a shooter at Pitfest. And now we're in this situation where we think that there is this mass casualty happening. There are no details yet. And so in this last hour of a 12-hour shift, this department is now thrown into this uncertainty of what might be to come here.
Yeah, I think you can really see the dread on everyone's face in this moment and the kind of fear around both the gravity of these types of events, but also just the amount of complexity and work that is coming their way. It's a scary moment.
Yeah. So in my experience, thankfully, I've never been involved in a mass casualty of this scope that we're about to see. But in the emergency departments where I've worked, there's often a phone that connects to emergency medical services, to EMS. And so if there's an expected large number of patients, more commonly, that's not something as terrible as many casualties as a shooting, but rather like a multi-vehicle accident. So it happens pretty frequently that the phone will ring and whoever is in charge of picking up that phone, sometimes it's a doc, sometimes it's a nurse, and you can kind of see them on the other line going, okay, we're expecting 3 patients or 5 patients or 10 patients. And if it's 5 or 10 patients, that has the ability to completely overwhelm the department. While I have not thankfully, again, been in a situation of this scope, I've certainly experienced that moment of like, they're telling us something on the phone that something really bad is about to happen and a lot of very sick people are about to come, and what are we going to do about it?
The night shift is going to be here soon, but we are going to need more help, especially from surgery and anesthesiology.
MCI group text and email went out to everyone, including transport and environmental services.
Okay, good. Everyone's going to want to come in to help. Keep enough in reserve. Tell them to come in 8 hours later to give us a break. And can you try and reach Jake?
Of course.
Yeah, I think there's something maybe worth calling out there, which is that because we've shown other scenes where the waiting room is packed, right? And so it's not that the 5 or 10 people in itself is an overwhelming number for the department. But I think what we're implying here is when 5 or 10 people are coming through that phone at the same time, there's an implication that they're all pretty sick. So from a resourcing perspective, it's all hands on deck, which you can imagine handling, one at a time of those. You could have all of the hands on deck for that patient, but really have to flip into a bit of a different mode when there's multiple patients coming in at the same time.
Surgery's got to call in the cavalry. We're going to need all 25 ORs.
Ahead of you. 4 ORs are prepped and staffed, and we're working on getting the rest up and running.
Every patient in the ER needs to go up, beds or no beds. They'll get better care in an upstairs hallway than ignored down here.
So he's just being so smart here. I mean, both of them are like thinking about all the things that need to happen quickly.
Next cap.
Pharmacy needs to come down, open PDS. They also need to bring up all the narcotics, paralytics, and sedatives that they can.
Consider it done.
So narcotics, paralytics, and sedatives. So narcotics for pain control, paralytics for intubation. So if they're going to put a breathing tube in somebody's throat who's not breathing, they may need to paralyze the patient. That's what we typically have to do to put in a breathing tube. The vocal cords are going like this as the patient's breathing. And so when we intubate someone, we paralyze them so the vocal cords stay open. They briefly stop breathing, we put the tube in, and then we breathe for them through that tube. And sedatives, once somebody's intubated, they need to be sedated so they don't wake up and try to pull the tube out or something like that. And also, if there's any kind of surgical procedure that needs to happen, the patient might need to be sedated for that as well. We talked about that previously for the ankle reduction.
Right. And I think there's, we're going to see different moments of orchestration, I think, throughout this episode. And I think invoking this idea of the kind of the symphony or the orchestra. You just gave one micro example of that, which is the meds in a specific order in order to successfully do an intubation. And I think we're going to see kind of levels and levels of that type of coordination.
EMS will be overwhelmed. Most will probably arrive by car, several victims per vehicle. Triage will decide who goes where depending on their injury.
Every department will have a designated primary who will oversee their staff. If you need someone, look for the vest.
So it's so good. It's so great. I feel like this is great television, and it's really on point with what someone who's really prepared for this type of situation would say and do in the situation. They have a plan. They have the equipment that they need. Everything's already been pre-stocked. And yeah, it's just like a case study in how this should be done in the real world.
Yeah, there's a very specific type of leadership that is being exhibited here, which is this like true crisis leadership where it is essential that Dr. Robbie exudes a very high degree of confidence and control over this room. And you're seeing this reassurance that they're also doing. They're kind of subtly slipping in. We're going to get through this. It's going to be okay. Right. These notions, because they're showing everybody in this room is terrified. They kind of showed the faces as he's giving each of them a different responsibility, and they're all working through what that is, how they're going to do it, and just the weight of responsibility, which is, you know, maybe more than they've typically had in this department, which is they've primarily been working as a team, and now they're getting split up in a way, which is a difficult thing.
We're all going to have walkies. We can get you whatever you need.
No patient goes into a room unless it's a trauma bay, and they will have 4 patients each.
By the way, an hour 12 of their shift heading into this, which is, you know, obviously very difficult, but they do have the benefit of the night team coming in. So in a situation like this, at least there's additional personnel available.
Okay, triage is going to assess and assign every patient to a specific zone with colored slap band. Patient who comes in with a red slap band goes to the red zone, which is the trauma rooms with overflow out here. These are the most critical patients who will die without immediate attention.
We should touch on this triage protocol. So this is an important kind of central clinical theme of this episode. So these mass casualty incidents, MCI triage protocols, here they're using red, pink, yellow, and green. This is a system that's been devised, and there are different variations of it. The red and yellow and green tend to be the most standard, and then sometimes there's a color in between, like orange or pink. But these systems that have been devised to quickly triage, as Dr. Robbie explains, people who are experiencing an imminent life threat, so are about to die if intervention isn't done, people who have an hour or so to survive if nothing is done. That's what we call the golden hour of trauma. So basically you have an hour to fix them or else they'll die.
Yellow zone is the north corridor, good vitals, talking. But a yellow can change to a red if they go south. You gotta stay on top of them, even if they seem stable. Green, minor laxant sprains, they go to family medicine. Black and white bands are DOA, imminent death. Peds is now our morgue. Let's hope we don't get too many of these.
Yellow patients who have an extremity wound. Again, this is where the classification can differ across various systems, but it sounds like they're calling yellow an extremity wound. And then green is basically people who are well, potentially like the walking wounded or somebody with a scrape that's not a severe injury. As the patients come in, you'll see them triage. And, you know, on one hand, it's kind of a terrible thing because you see the doc walk up to the patient and triage them as, you know, and black is less when they've been talked about where the patient's just deceased, that nothing can be done for them. And, you know, it's kind of terrible to see that process take place, but it's, again, using the resources to the extent that we have in that situation.
Yeah, he does slip in the black, but says it a little more quietly than he says the rest of them in that moment. And yeah, it's a tough thing to think about, but it is obviously a crucial moment for the department.
The goal is to triage each patient in 10 seconds.
10 seconds, got
Mental status is AVPU, alert, responsive, verbal, responsive, pain, unresponsive. Next, do they have a pulse?
So we're about to get to the first patient here. Before we arrive at the first patient, I want to say if you're enjoying the video, make sure that you like and subscribe. And if there are other scenes that you want to see us react to, make sure that you leave that in the comments. We're reading every comment and we want to hear from you.
I got 4 shooting victims.
What's your name?
Duncan.
Show me. Right chest, strong radial, pink.
What's this?
That's priority boarding. You're going to be okay. Back wound is red, shoulder is yellow, neck wound is red.
So this guy who got shot in the chest, which is obviously a life-threatening injury, he's pink. So the notion here is that if he's not treated within an hour, he'll die. But he doesn't have to be treated in the next 5 minutes, unlike a red band would.
Was it the radial pulse the main reason why he was able to say 1 hour and not immediately?
Yeah, and he had good mental status as well, that he, you know, was awake and alert and was able to, you know, hold that conversation that happened quickly.
What happened to your leg?
I got hit by a car when we were wheeling.
Okay, we'll see you inside too.
Put me in, coach.
You're on triage with Shen.
10 seconds a patient, right?
You got it. Let me know if you need any help.
So the common wisdom is that the most experienced doctor is the one who should be performing triage, which is sort of counterintuitive because, in most emergency departments, every day there's a triage nurse out front. The patient's encounter first, they triage the patient and send them back. In this situation, that triage is really making a huge determination as to what's going to happen to this patient. That if you triage somebody pink who should have been red, then they might die in the next few minutes. So the wisdom is that the most experienced doctor should be the one triaging in an MCI. That doesn't always happen, but it's interesting at least just to think about why that would be, and just it's a different way of thinking about the process.
Yeah, I think it's interesting to think about how challenging triage becomes when the amount of information you have is limited to 10 seconds. Yeah. Right? Like that type of clinical decision where you don't have time to even ask, right? At a minimum, we would think about asking a litany of questions to better understand how somebody's feeling and things that are going on. And in this moment, roughly 2 to 3 pieces of information and a little bit of gut instinct that probably pushes you in one way or the other when you're on the border and not sure. Yeah, like you said, a very powerful determinant of their course and just an extremely difficult thing to do as a physician. It's something that a lot of us don't have that much experience doing. And so I think one of those moments where someone who's been around longer, has seen a lot more traumas, has seen more sick and non-sick patients can really step up.
I'm in. Bag her.
Oh, next pouring in.
I'll take her up. Dr. Mohan, that kid came in with his mom. She says he's deaf.
Hook me up. Squeeze in 2 units, 1,500 out, buys him a trip to the OR. If he stabilizes, surgical ICU instead.
So she's putting in a chest tube, which is a tube that goes into the pleural cavity. It basically goes through the ribs and up against the lung. It treats a collapsed lung or blood in the chest cavity, which is called a pneumothorax or a hemothorax. So this patient has a hemothorax. She put in the chest tube, it's draining blood. And the other doc is saying if that 1,500 cc's of blood comes out of the chest tube, then the patient should go to the operating room because that indicates that they have massive amount of bleeding in their chest cavity that's going to need surgical intervention.
IO's in, go with Opaz. When there's no time, bone marrow infusion's as good as an IV. Robbie, stabilize.
So this is something super cool that we're super familiar with as emergency clinicians, and maybe the public is not as familiar with. This is called an IO, an intraosseous line. This is a specialized drill. It's pretty small. It's like this big. And at the end, there's a needle. And you basically hold the needle against the skin, right against a bone, either your arm bone or your tibia, your leg bone. And you drill it. The needle goes into the bone. That inner piece, that inner cannula comes out. And then you attach an IV tube basically to it. And you can infuse blood or fluid right into that bone marrow, and it's as good as an IV. The reason that they're using it here is if there's a delay to getting IV access and you need to resuscitate somebody who's critically ill, the IO gets you access pretty much immediately. And while it can be painful, it's generally used in patients who are not awake and where this is not going to be their main problem to have a needle going into them. It's they have some other major injury or major issue.
Yeah, and folks may recall times in their life where they've either had an IV line placed or tried to get blood drawn when they're dehydrated. It is, right, it's not easy to be able to get access through the veins. So you can imagine in a moment like this where somebody is bleeding, right? So their blood volume is low. They are essentially extremely, extremely dehydrated in that way. It's possible, but it's hard to get good IV access in these moments. So having this kind of foolproof mechanism in our back pocket is really a save sometimes.
Exactly. Yeah. And when you're talking about somebody who's lost this amount of blood and you're trying to save their life by giving them blood, a blood transfusion, which is what they're calling for with the O positive and O negative blood, those seconds are the difference, can be the difference between life and death. So you don't want to be messing around with an IV when you can just grab the IO, it's in and you're done.
Yeah. Yeah. 100%.
Document the tourniquet time, mark the arm. Mark the chart. Let it down briefly once an hour.
4 morphine, repeat if needed.
So tourniquet, this is something that, anybody can be familiar with, something that you can have in your house or in your car. So this person has an extremity wound that they're bleeding from. So if they lose enough blood from their extremity, from their arm or their leg, that can be life-threatening. And in an extremity wound that's at the end of your extremity, you can put a tourniquet, we say proximal, meaning closer to like the center of your body, proximal to the wound, and stop that bleeding. One, it's really painful because you're cutting off circulation to the arm. And if it's on there long enough, you get ischemia to the arm's not getting enough blood. You can start to get death of the tissue or even lose function of your arm. So why would we do this? Well, we're doing it because it's going to save their life, because the alternative is for them to lose all of their blood out of their arm. And so that's what we're seeing here. Like, this person's in a lot of pain. They're calling for morphine, but they have that tourniquet, and hopefully she's going to be stabilized with that tourniquet. Now there's some time. Now she's no longer having a life-threatening amount of bleeding. Even though this wound needs to be fixed, we can't just leave her arm like that. Now bought some time to stabilize her. So this video is supported by Duration Health. So I'm the founder and CEO of Duration Health. We're telehealth for wilderness and disaster preparedness. We offer doctor-prescribed medical kits for off-grid living and travel. The way that it works is before your trip, you go online, you talk with one of our doctors. We prescribe medication in advance that you might need if you get sick. So not your daily medicine, but rather things like antibiotics, anti-nausea medicine, EpiPen. We package it all up. We ship it directly to you. You bring it with you so that if you do get sick, you already have everything you need to feel better. Check it out, durationhealth.com. And again, make sure you like and subscribe if you are enjoying the content.
Responsive, had a weak femoral, lost it.
2 units of blood. There's no response, call it. No pulse, no OR.
Gunshot to the head. Still got a strong pulse. This one can make it because the intracranial bleed can decompress through the bullet holes.
Walsh, neurosurgery in-house?
Yes, send him to the neurocrit ICU. The trios from there.
So there's like so much clinical information just like being dropped here and there. So this guy, they say, is a gunshot wound to the head, but the bullet holes in his head are allowing the brain to decompress. So if you have a head injury, the thing that generally kills you from a head injury is that the brain swells and the skull doesn't allow much room for the brain to swell. And the brainstem herniates, meaning it gets pushed down through the opening at the bottom of the skull. And when that happens, it's fatal because the areas of that brain that control your breathing, that control your autonomic function, are in the base of the brain. And when that all gets squeezed through, then you die. In this case, he's saying that the holes are actually going to allow the brain to swell out at herniating without it getting pushed through the bottom. And that is going to be life-saving for this patient.
Right, because it sounds like in this moment he's deciding, is this person going to make it or not? And they have a gunshot wound to their head, right? So most folks, if we're thinking about this triage, you might be like, that's too tough. And we may not be able to save this patient, but he's kind of acknowledged this one aspect of it that means that, and it sounds like they sent him up to the neurology or brain focused ICU intensive care unit for him to be monitored and probably go to surgery at some point.
Some help with an airway.
What is it?
GSL beats the neck with expanding hematoma and distorted anatomy. Can't intubate him, probably hit the carotid.
Okay, I'll do the airway.
This is a patient who has an expanding hematoma in their neck. So he's got this injury to his carotid artery. It's bleeding. It's causing that hematoma, that bleeding under the skin, to expand. And so it's basically like pushing into the structures of his neck and closing off his airway. So when the other doc goes to intubate the patient, they're not able to see the vocal cords, or they're not able to pass the tube because of that swelling, that expanding hematoma in the neck.
Too bloody to see a bougie.
Not for this 3-step process. Step 1, scalpel. Step 2, finger. Okay, railroad in the tube. Okay, bag him.
The dressing is off, Foley's in. Local balloon.
30 cc's in.
He's got this bleeding wound in his neck. So what they do is 2 things. For the bleeding wound, he puts a Foley catheter into the wound, which is normally meant to be a urinary catheter. There's a balloon at the end of it. If you've ever had surgery and then you end up with a catheter after the surgery in your bladder, that's a Foley catheter. But instead, they're repurposing it here to put it into this neck wound. They're blowing up the balloon and stopping that bleeding. He's clamping it afterwards, and he's like, oh, look how dry it is, meaning like we've stopped the bleeding from that wound in the neck. And now the airway, usually we put a breathing tube in patients' throats through their mouth. But in this case, they can't see. They can't get into the airway through the throat. So they're doing what's called a cricothyrotomy. They're making a hole in the neck here. And he does a particular technique to do that, scalpel finger bougie. So he cuts the neck, he puts his finger, feels the cricothyroid membrane, cuts through it, and then passes the bougie, which is that blue plastic thing, puts it through the hole into the trachea, into the windpipe, and then passes the ET tube, the endotracheal tube, over that blue bougie. So now he's secured the airway through the neck rather than from above through the mouth. They've stopped the bleeding. Patient can breathe and the patient's not losing blood, and then he can go to the operating room.
Yeah, two pretty life-threatening problems happening at the same time there that he fixes. And it also just speaks to the number of procedures that as an ER doc, you have to have in the back of your mind and be able to do on kind of a moment's notice. And some of the creativity that comes in this type of problem solving, right? Like this is not, he didn't like pull up some algorithm for this exact thing. He was just like, how do I stop the bleeding and get an airway into this person as soon as possible? And it's wild to see.
Any idea how many more come?
Incident command is sending all these ambulances back to the scene for more victims. We may not even be halfway through.
Jesus, when is this gonna end?
You know, there's a lot of clinical things that we talked about here that are not even to say the word interesting, but complicated clinical dynamics that we think through as docs here. But I think the big message of this episode is that there is so much pain in these moments across patients, families, in the mind of each of these doctors. And it is really horrible. And even, you know, we saw that moment there at the end where there's a fear around the shooter coming to the hospital and, you know, Dr. Robbie's kind of beating drum of like, just focus on the patients and we'll get through it. It's a hard thing to do as the doc in those moments, to kind of put aside all your own fears about your own life. And in that moment, of course, it's the only thing to do because that you have to show up and be able to support these folks who are actively dying and not just have a threat of it, but it's hard to see.
Yeah, I mean, well said. I think that's the takeaway, you know, ultimately from all of this is like the human element of it. And I think that they do an amazing job portraying that. And yeah, I mean, just terrible all around and really well portrayed, I think, in this episode, both from a medical standpoint and a humanist standpoint.